Good afternoon, everybody. Thank you for coming to this presentation today. We both feel quite passionate about this subject, and actually it's very topical at the moment, seeing as I'm sure you're all aware of what happened last week with a professional England ladies football player. So we have been in talks with the insurance company, and we've been doing this for quite some months now, because it's become quite apparent that this is something that we need to look at. So today, Felicity is going to kick off this presentation with a case study that we're going to talk about in detail. We're then going to go to Sarah Elkin, who is a respiratory physician, and then we're going to go to me, and I'm going to do a little chat, and we have a little handout for you. And then we're going to go to Flora, who is the defence lawyer at Lockton and a specialist in this area. So hopefully there's not going to be too much, it's not going to be too heavy. You're probably all going to have to go and sit in a dark room afterwards, but I'll pass over to Felicity. Thank you.
Thanks. Hi everybody, it's lovely to be here. Now I'd like to say this is a case study, this is a story, yeah? I'd like to say sit back, relax, fold your arms, yes, and listen, but it's not quite a sit back and relax, okay? But it does start with one afternoon in December, just before Christmas, and a practitioner is about to close down her practice, yeah, but not yet. So I'll show you what this is what I need, isn't it? Where's the little clicker? Oh, there it is. So I'm doing two different things here. So where do I point it to there? No, there. Sorry, wrong one. There, gone. Okay. So let's just look at aims. What are our aims with this? Inform the membership of a case of pneumothorax in order to help us to review our procedures, understand reasons for occurrence of pneumothorax, and review processes of reporting. Yeah? All of this to improve patient safety, which is what we're all about. Okay, so I'm going to present a case of pneumothorax, going to consider the possibilities of what might have led to the pneumothorax, and inform the membership of the occurrence of pneumothorax. That will come out in time. Then we're going to have Sarah looking at informing the membership of lung physiology in relation to pneumothorax, including what happens in hospitals to correct it. It's a really useful thing to know. Yeah, and then we're going to inform the membership of the role of the BXC and the insurance company. Yeah, because this is what it comes to. Okay. So this is the story. So 14th of December, a practitioner gets an email from a patient who's age 47 wanting treatment to support FET, frozen embryo transfer. The patient had frozen embryos abroad, made from partner sperm and donor eggs, yeah, and so is planning on going abroad to have this procedure. Okay, so she had a 2-week window for treatment to prepare before flying abroad. So that's an important factor in this, because the practitioner's planning on stopping work on the 17th. This is the 14th, so she's got to fit this person in before she finishes work. Yeah. She made an exception for this patient, so found a window to treat her and decided to treat her the next day. Yeah. This person had multiple IVFs before, and this was her third and last from donor eggs. All right. So she decided to start treatment the next day, as it gave her a chance to do a treatment before she started on the oral transdermal estrogen. Yeah, so the idea is to treat the next day. Okay, so her diagnosis. I'm not going to go into the whole thing of IVF and that, yeah, and what goes on. I'm not approaching that, but I've got some details if you want it. So diagnosis of the patient. Blood and yin deficiency, and so her treatment principle at this stage is to nourish the blood and the yin. She's not, remember, this treatment isn't about the cycle at this point, so this is before the patient has started the whole process of hormone treatment, which therefore would be a different diagnosis, a different treatment process. Yeah. Okay, so the patient was prone on the couch with arms by her side, and these are the points that she's done. Okay, kidney 3, bladder 15, 17, 18, 21, 23, and then she's got heart 5 and pericardium 6 in as well. Okay. Now, the practitioner informed me that she had found it difficult to get chi and did manipulate the needles quite strongly to get chi. Yeah? So that's one of the factors in here that we need to think of. Okay. Also, the patient was slight, but as far as the practitioner was concerned, had quite well-developed paraspinal muscles that she was going into with those points on her back. Sorry, I'll just take that off for a second. Yeah? Oh, it doesn't go backwards. Okay. Yeah. The back points was a transverse oblique on all those back points, certainly on the bladder 15, not all of them, obviously. And the practitioner put a meditation tape on, and the patient was breathing deeply into the upper back, is something that she observed with this patient, yeah, in line with the meditation tape. Okay. Lying on her front, yeah, lying prone, yeah. Patient was prone on the couch with her arms by her side, yeah, nose in a hole, yeah, okay. Transverse oblique is the, perpendicular, transverse oblique, angled towards the spine. The normal way you do points on the upper back, yeah? It's the normal recommendation on the upper back, yeah? So that's what she's doing. So, immediate effects. The patient got off the couch and said her back felt uncomfortable and is pointing to that point, bladder 15, on the left-hand side. On examination, the practitioner had a look at it, couldn't see anything in particular, no surface evidence. So the practitioner asked the patient to ring her later just to confirm, see how she was. All right. Now, she did say there was something in her at that point she had a suspicion of something. Is this just a normal muscular injury from tissue trauma from the needle? But she said there was something in her. So interestingly, she says one of those things, those little niggles that you get, yeah, you need to be aware of those. Okay. The patient rings shortly after leaving around 3 o'clock and says the muscular pain in the back on inspiration, but she's not saying she's breathless. And I think that's quite an important one to know. She's not saying breathless, but the muscular pain and but pain on inspiration, you could still think a muscular injury, yeah, tissue trauma, yeah? So you could still be suspecting that one. The practitioner says, would you call back later? Okay. The patient calls later and says the pain has settled and it's now uncomfortable to breathe. So no more pain, but it's uncomfortable to breathe. The practitioner asks the patient to come back later that evening. So she is following up with this patient, at 2 calls, following up with the patient, yeah, for an examination. The patient reported there was still pain as if breath was catching in her chest. Then she points to her left side, just lateral to the lower sternum, and this is when the practitioner thinks this is a pneumothorax. Yeah? She says this to the patient, and the patient concurs and says, yes, I think it is. Okay, so they come to that agreement. So this is the evening of the first treatment. Yeah? Okay. Now, the practitioner offered to take the patient to A&E immediately. But the patient didn't want to go. Yeah, COVID, she doesn't want to go to a hospital. Remember, she's flying out in a few days' time abroad for this IVF treatment. We're coming up to Christmas. Yeah, she doesn't want to go to hospital. So she consults a doctor who's a relation who thought that pneumothorax was unlikely and said, take some Nurofen and go to bed. All right? But before the patient left, the practitioner marked the point on her back, yeah, where she thought it was. She also gave the patient a needle, marked the depth that she'd put the needle in, and explained it to the patient and said, take this if you go to hospital. Yeah? So, yeah, a good point in terms of follow-up for something that you might be doing. Okay, so the patient left with a plan. Go home, do your oxygen level, take your oxygen level, take anti-inflammatories or analgesia, and they'll talk tomorrow morning. Right? So she's left the patient with a plan, which I think, again, is an important piece of advice in terms of doing this. Okay, so The patient texts later that evening to say that the oxygen level is okay, she can breathe better, but she says, I'll go and get an x-ray tomorrow. Yeah, I'll follow it up tomorrow, so she goes to bed. So the next morning, next morning, she says it's sore to deep breathe, but could manage deeper breaths. She's COVID negative. She takes a test in case it's tied up with that. She's got a breathy cough, positional pain, pulse 80 to 90, oxygen level 95 to 98, plans to see the GP. She goes to the GP. The GP notes reduced air entry in the lungs and sends her straight to A&E. All right. So 50% pneumothorax on the left side. She's put on high flow oxygen, which is the first thing that's done. Sometimes they can spontaneously recover with that, but the plan was, if not, then they have to put in a drain. Okay. The hospital at that point says to the patient they thought a 10 millimetre could puncture on someone's slight like this patient. They have said this in the hospital. But what we're not sure is, did they take the angle into account? Who knows, yeah, at this point. The x-ray shows not much improvement later that day, so they put a chest drain in, and the patient is in hospital for 2 days. Okay, so there we've got the story. So the practitioner followed up with a visit, apologising, and put the patient in touch with the BACC. Okay, so followed that up with, this is how you have to go down. This could be a case, yeah? So put them in touch with the BACC, explaining the treatment. And moving forward, so we need to think about what the points are in this. After the new year, so we now go through Christmas, after the new year, the lawyers are brought into it, and they say, don't have any more communication. Yeah, so any communication now goes through the lawyers. But this is quite 2 weeks later. Really, this happens because this is just before Christmas. Everything's locked down. Yeah, there are all these other factors in it. Okay. So let's think of the learning points. All right. So we're trying to pick out what's gone on. The length of the needle used on the back is the important one. Remember, this person's using a 40 millimetre needle on the back. Yeah? Not going in 40 millimetres, obviously, but does a 40 millimetre allow a needle to go in further than you think? Yeah, a lot of people would recommend a 30 millimetre, 25, 30 millimetre needle. Yeah? Still within, the depth is within what we say the range is, but a pneumothorax has happened. Yeah? So, obviously, the needle's gone in too far. Straightforward, really. Before she goes oblique. What you'll put it in oblique. I mean, I think that'd be a hard thing to know when you do an oblique, how deep the needle actually is. Where's the tip of the needle? Yeah, where's the tip of the needle under the skin if you're oblique? Yeah, obviously it's gone through beyond the rib level. Yeah, so it's through quite a strong, as she said, yeah, paraspinal muscle, and down between the ribs. It must have. Yeah, so you've got that level of depth, haven't you? That must have gone in. All we can say is it must have, because she got the pneumothorax. Otherwise, you wouldn't know. Yeah.
As according to Dedman, the practitioner was quite adamant that she had, and was very surprised that this had happened, and that the needle had in fact gone deeper. And I suppose what we want to do today is discuss the reasons why that is, why she put the needle in deeper than she thought she had, because I think that's what's happened. Yeah. So she thought she'd kept to the
she thought she'd kept
depth.
To the right depth. Yeah. Was aware of it. Yeah. Yeah, she was considering the size of the patient, but she said the back muscle. She was a slight person, but strongly developed. Yeah, had good paraspinal muscles. Yeah. You can, but I think in this case it was too much of a coincidence that you put the needle in and the person has the pain where you put the needle in. Yeah, that's all we can go on. Yeah, we have to assume it was that needle that did it. Yeah, that it was bladder 15 that was the point that did it. Yeah, that was too much of a coincidence. That's all you can think of. So, first is the length of the needle, and we have to be aware there then of what we're doing. She also said, it was interesting because she said, when I put the needle in, she said, usually you can tell the change in tissue, yeah, as you put a needle in, and you think you're within still in the muscle. Yeah, but obviously not. So there we go. Yeah, but that's you know, we think we've got that sense of how deep we're going, yeah, even in terms of that, but all we've got at the end of the day is we've caused a pneumothorax. So the next bit that she said was the breathing. Now, it's interesting because the only case I've heard about in the past of a pneumothorax was one where somebody put a needle in the side, yeah, and then the patient said there was pain and the practitioner said breathe into the pain. Yeah? And that caused pneumothorax as well. So, and the other one we know of was quite vigorous, deep needling, yeah, on a back point, was somebody being, yeah, really doing deep needling, yeah, and caused it. So we do wonder whether the breathing into the back. So certainly in future, the thing is when somebody's lying prone and you say breathe deeply, they're going to breathe into their back, into their upper back, because you can't breathe into your belly. Whereas normally when she puts the tape on, she said for IVF, the person's lying on their back and she teaches them to breathe into the belly. Yeah, because that's where you want the treatment to go, is into the belly. So, yeah, so don't have your patient breathe deeply into the back is one of the learning points. And what we want to know, and something we'll follow up with Sarah, is it possible that if you're just touching, I mean, the lungs don't pop, is it possible you're touching, yeah, the pleura, and then the breathing is causing a tear? Yeah, if you're just on the edge. Yeah, that's something we don't know either, but it's just a possibility we're putting out there at the moment. Whatever, don't have your patients breathing into the, don't breathe, tell them not to breathe. Yeah. And certainly don't breathe it. She didn't have pain at that point, but don't breathe into the pain. Now, following up with the patient if there is a problem, I think in some ways this practitioner did very well. Yeah, she took this seriously. She followed up. Yeah, she followed up numerous times with this patient. Give me a call back. Let's see if it's okay. Saw her again. Was going to take her into A&E. Yeah, all of that going on. Admitting mistakes and thinking what is the possibility. Yeah, I think that's another one. We have to think that's happened. What have I done? Yeah, what could be the possibility there? And I think that's something we have to really take into account. And that listening to your instincts, listening to those niggles that say, oh, God, is that what's happened? Is that what's happened? Don't be afraid to think of the worst possibility. You might have to call 999. Has anybody had to call 999? Yeah, one. I've called it once with somebody I think was about to have a stroke. Yeah. You couldn't move. Okay, okay. It's quite traumatic calling 999 to your practice, but you have to do it sometimes, yeah? So just be aware that you have to do it. We deal with, in medicine, you're dealing with things, you're dealing with sick people, yeah? That might have to happen. Okay, write up your notes thoroughly. Yeah, that's another really important one, is keep good notes. You know, the times that we don't follow up with our notes, all I can say is, after going through this case with this colleague, I keep much better notes again than I used to do, so I'd got slack about it. That's important. Contact the BXC. Contact the BXC. They're fantastic, yeah? Really supportive. That's when I say, when people say, oh, what's the point of joining? You know, what do they do? It's a lot of money. This is why you join the BXC as well. Apart from great conferences and lots of great colleagues that you meet up, but still, yeah, that's why you do it. Fill out the adverse incident form immediately because it helps get your thoughts in order. Yeah, that's another really important one, and Hannah will go over that, and write things down while still fresh and talk it through with a colleague. So what happened is this person contacted me, yeah, and talk through, yeah, what went on, how do you do this, how do you follow up, etc. Yeah, that's the other thing. Talk it through, open up, talk to others. So discussion points, and hopefully we'll do that afterwards when we've heard the story from others. How does the pleura work with a pneumothorax? That's something I'm interested to know, that relationship with lung and pleura and the pressure between the two. The other one that was really interesting is the patient was empathetic to the fact that mistakes can happen. And the practitioner wondered if it made it easier to communicate, and she wondered what if somebody had been more difficult. So it was easy for her to communicate with the patient. So it's an interesting one to take into account, I think. We need to be aware of what we follow up as a professional, irrespective of how the patient responds. Yeah. What is the issue of negligence and hopefully in admitting fault? And hopefully we'll talk to Flora about that. Then the patient commented on a lack of consent form, did not feel that the consent was adequate, was unsure if she'd known that there was a possibility of pneumothorax, points over the back, would she have had the treatment? Yeah. If there was, what the possible risks, what is that possibility, etc. The practitioner has completely overhauled her attitude to consent since, which is interesting, and since watching Flora's good webinar before, on consent, recommends that we all should watch it. Okay? So that's the other important thing. All right? So I've just put up a couple of things there, but I'll put those later. We'll talk about things first. These are some of the research that's out there. Yep. Good. Okay, that's my bit of the story. Now we'll hear from Sarah.
Yes, thank you ever so much for that, Felicity. We're going to put Sarah on the screen. Sarah, there she is, look. She's going to present to you today, and hopefully we won't have any technical issues. So, Sarah, over to you. She's a respiratory physician, but please introduce yourself, Sarah. Thank you.
Hi, everyone. I wish I could say it's nice to see you, but I can't. So I hope you're all sitting comfortably. I'm on a lovely beach, having a good little relaxing time. I'm going to pull up my slides, and just as a starter for 10, I'm a consultant in respiratory medicine. I've been a doctor for many years, and I do acute medicine too on call. And in many ways, that case made me feel slightly uncomfortable. So I always reflect on how a case makes me feel. It was a very difficult time through COVID, and we actually had many patients that didn't want to come in or see us. But our duty as healthcare professionals is really to explain risk to people and to ensure that we advise correctly. Whether people take up our advice is completely on them, but our role is to advise. So I'm going to pull up some of my slides now. We'll go through a little bit more of the anatomy and what we see and do as doctors. So let me come and see that. And just for a little bit of background, I was a physio before I was a doctor, so I often come from a slightly different angle now. This is now an intelligence test that I sometimes fail, so bear with me. Share screen. Share. So someone say yes. When I go large on this, I won't be able to see what I'm doing. So
we can see the presentation now.
Can you see that? Fantastic. Yep. Thank you so much. So here we go. So I'm going to give an overview of pneumothorax and try and concentrate a little bit about how it may occur with acupuncture. So just a reminder of what we're talking about, guys. We're talking about when the lung collapses down, and patients will often say this. They'll say, well, my lungs collapse down, and it's because air is introduced through the parietal and the visceral pleura. Sometimes that can build up and you can have a total collapse, and sometimes it's just a little bit. So there's variable sizes in pneumothoraxes. So what I'll aim to cover is a diagnosis linked to acupuncture, as said, causes, so I'll go through a few of the others, and management and the rationale for management, and recurrence and follow-up. So how might acupuncture cause pneumothorax? You've heard a few things before, but really it must be from excessive depth of needling over the lung area for many reasons, and it might be by excessive movement of the patient, but less likely. And using an inappropriate direction of the needling. There are other causes as well. Location may make pneumothorax more relevant. So always think about where you're needling as regards risk. If we're putting chest drains in, we always go in safe triangle. So we feel quite nervous about going over the rest of the thorax. So safe triangle or second intercostal space is where we would go if we had to put needles into the thorax. These are little diagrams shared with me just to make me understand what you do, and I immediately say, if we look at the intercostal spaces here, the second intercostal space we probably wouldn't go as medial as that if we were putting in. We put a little bit more lateral. Is there a risk there? Not always, actually. But the fifth intercostal space worries me a little bit more. So what I'm saying out loud is there is going to be an increased risk in some of the positions that you put your needle into. So be a little bit more aware of that as well. Thickness of chest wall, so that's an important factor, isn't it? Is pneumothorax more prevalent in people that are slight or big? The evidence is not really there. But all I will say is if you look at, I'm going to get this off me so you don't have to see me there. If you look at the second intercostal space, in quite a large study, it was in 2012, they looked at a lot of patients' sizes and chest wall thickness. So up here, the right chest wall is less deep than the left. However, at the fifth intercostal space, the left is less deep in the individuals, and those are in millimetres if you go vertically measuring in. So it's not that deep, guys, and that's an average. So moving on. So is it common with acupuncture? I think the incidence really is unclear, and I think that's really important to say. I suspect it may be more common than we think, in that some people might have pain and think, oh, that's all right, and it might just resolve on its own. It's a hypothesis, or it might just be as rare as it says. But there are quite a few case reports out there when I started looking. And actually, even incidentally, talking to colleagues, whether they had seen this in their private practice or NHS, many had. So not many, but many people had seen one or two. There's one series in the centre in 2011 to 2015 that found 17 cases, so over 4 years, 17 cases. And they were a centre that was attached to people that did acupuncture on site. And then another tertiary centre found 5 cases in a 5-year period. So they were a busy tertiary centre that looked at all their notes. There's one literature room review looking at harm from acupuncture. 78 case reviews or papers were included with 193 patients, and they found the commonest thing that occurred was pneumothorax with needling and trauma, and then hepatitis was number 2. So it appears rare, but it is the commonest mechanical organ injury. And there has been, and I think it's really important to remember this, one death from a bilateral pneumothorax. So if you needled and the poor person was unlucky enough to get pneumothoraxes both sides, that ain't good. So you need to always remember that as well. So rare, but serious. So that's the way I would describe it. Rare, but serious. So moving on. I'm going to show you a few slides about what may make it more likely. So this is a patient that smokes, so they are going to be more at risk from secondary pneumothorax. They're probably the same amount of risk from a primary or a traumatic pneumothorax, unless they're very slim, which case the risk is probably increased. So this is centrally lobular emphysema, when emphysema occurs within the lung substance. And this down here is paraseptal emphysema. And you can see that the lung has big, we call them bulli, towards the outside of the lung. So probably more likely to get ruptured should a needle touch those. I'm going to show you a few more. So that is a big bully at the top of the lung. So again, if one is needling around the apex, which looks more rare, you might have more chance of rupturing that bully if going through the pleura. So I'm going to give you a bit of time to think about these films. So this on the left-hand side is a normal chest X-ray, and you remember we image people from posteriorly to anteriorly, so you always see the heart is a bit smaller on an AP erect. But if you look at this X-ray, the most obvious thing that I want you to concentrate on is all the lung markings have gone, so it looks really black. And here, lots of white. So really black, lots of white. And if you compare it to here, you can see a little bit more concerning, lots of black. So here you'd think, oh my goodness, there's a right-sided total pneumothorax, missing the fact that there's also a pneumothorax on the left side. That is not something that I would ever want to have personally. But of course it can happen, and normally it happens in a road traffic accident or other effects of surgery perhaps. So presentation, looking at the evidence from acupuncture, the most common presentation is chest pain. So people will say, you know, I've got a bit of chest pain. Sometimes people might describe shoulder tip pain when it occurs. That might even be one of the oddities of it. So if people describe shoulder pain when you're needling, be worried and take it seriously. So if you're needling somewhere different and they say, oh, my shoulder hurts, not good. Dyspnea, so breathlessness, is the second commonest sign, and they can occur together. Important to say the presentation can be delayed, almost like the other case. People can present about 12 to 24 hours later, and often people can manage breathlessness quite well. And also, SATs are maintained for a long time, guys. Don't be reassured by saturations of oxygen. We know that actually you need to be really lung completely down or not breathing very well to have a decrease in SATs. But delay is a concern. So every time a patient with a pneumothorax takes another hour or two to get to be examined or get to casualty, that's not good, because the lung can go down. What you don't want is the lung to be completely pushed, or tension, i.e. pressures put on the heart. That would be not good. They do appear to be commoner on the left side, and maybe you could think about that and why that may be. I was trying to think a little bit, and maybe it's lower down, the chest wall is thinner, but please do give your view after this. And again, remember the right shoulder pain on insertion on the right-hand side. Diagnosis would be by chest x-ray after auscultation. Auscultation is quite obvious, actually. If someone's got a pneumothorax, you just don't hear breath sounds. Again, I want you to look on that. So everyone in your head, what side is the pneumothorax? So it's the left side, okay? You can see a line of the lung coming all the way down here. And the right side's totally up against the chest wall. So that's a moderate left-sided pneumothorax. Again, thinking about the other causes of pneumothorax, the most common causes are primary in someone that's already got a lung disease. So smokers with emphysemas, you remember those bully at the top of the lungs, they can go, and then air is let out into the pleural space. So it commonly occurs as a secondary consequence of smoking and lung disease. There's lots of other lung disease, which I won't go into, but that we would call that a secondary pneumothorax. Primary often occurs in people from 15 to 34. They're tall, they're slim, higher in females, and we call that a primary pneumothorax. And then you have traumatic pneumothoraxes that would be or behave in a similar way to primary, except one thing I'll mention. So why does it matter what the cause is? So what I want you to also think about, what does it matter what the cause is? Does it matter, is there a difference in outcome if someone has a pneumothorax from an acupuncture needle, or if they have a secondary lung disease? There absolutely is. So the importance to you is be careful on understanding the complexity of whether someone's going to recover or have recurrence. They don't often recur if it's due to a needle going in, if the lungs are fine, and so that's reassuring for the patient. It's likely to affect management. That's why we want to know what the cause is. It's likely to affect the immediate management. If someone's had a traumatic pneumothorax, they may have other injuries to the muscles or the space here, especially in a road traffic accident. And they may need to start antibiotics if they have had a road traffic accident or something inserted into their chest. Longer term management is also important to think about, especially there is a rare cause of pneumothorax linked to endometriosis, and if that was the case, we'd want to give hormone replacement as a matter to stop them. Anyone you see, please encourage to stop smoking, and if that's in your practice, that's fine. But absolutely, our duty of care is to help anyone that smokes to quit and to give them support to do so. We should also manage the underlying condition if it is a secondary pneumothorax. So what do? So sometimes we do nothing because actually if they're very, very small, they can re-expand at a rate of 2% per day. We have been a little bit concerned about this advice in medical circles recently, in that we have had some people that have been left to re-expand and not followed up, and actually the lung has gone down. So if we're leaving the lung to re-expand, we do regularly review that individual to make sure they're not getting worse and that the pneumothorax is being resolved. We sometimes aspirate, which means we put a needle into the space, as I demonstrated earlier, into the second intercostal space, and just aspirate through a needle out. We sometimes put chest drains in with an underwater seal that pushes the air out. So as people breathe in, the air gets pushed out through the underwater, and as they breathe out again, there's a closed space. We sometimes give oxygen to assist absorption of the pneumothorax, and very rarely we have to go to surgery. So we have to think about what we do. This is a really busy slide, but really to say that the number that we look at is a 2 centimetre. So if something is less than 2 centimetres, we may be able to aspirate and let someone go home with a repeat chest X-ray. But if it's greater, we tend to actually go down to chest drain nowadays. Again, this is repeating what I said about the 2 centimetres, but really to say it depends where you measure it. So I always say to my juniors when teaching, it's really important to make sure that you don't go for 1-2 centimetres when you've got 5 down here. So you have to go by the largest bit. Aspiration is very simple. It's quite successful, about 50 to 70%. But again, it really would depend on patient preference as well. I think if you've got a larger pneumothorax, they're likely to be more successfully treated if you do get a drain in. But again, some people say, well, that's a great big drain. I don't want that in my thorax, which is fair enough. This is a case of a man that we did choose to aspirate, 26-year-old, sudden onset of right-sided chest pain, so a primary spontaneous pneumothorax. And you can see probably 2 centimetres here, although larger at the apex. He really wanted to go home. He did not want to stay in hospital, so we chose to aspirate, and he went home, but he came back again. And actually, it hadn't changed. If anything, slightly larger. Went home again, and this is the thing about the delay. He then went to some conference or something that day between the last X-ray and this. So if we go back to that, so between this and this one, he was told to come back, and he came back even sooner, actually, a few hours later. And I think the biggest message here, guys, is it can go down quite fast. So that's here, and that was probably about 3 hours later. Drain, that's what the equipment looks like. So we have to cut into the chest wall and get the drain into the thorax. It's quite easy to do now, and gone are the days where we do this just by a big chest drain into the chest. It's done very carefully and after a lot of thought. And the chest drain goes in here, so it goes into the pleural space, and then the tube here comes out and goes into an underwater seal. So what we're trying to achieve is we want to do whatever's safe for the patient, we want to have symptom control, and we want the lungs to come up again. Recurrence, the most important thing on this slide is with trauma, so needles into the chest, there doesn't appear to be an increased risk in recurrence in studies if the patient has no underlying lung condition. I would say even if they have underlying lung condition, their risk of recurrence is going to be linked to that lung condition, not to the fact that they got a pneumothorax from the needle. So how might it be prevented? We've spoken a bit about this, and we can have more discussion, but probably my colleagues' consensus with needling should occur on the expiration breath, using the correct length of the needle for the point, needling in the right direction, so with large needles not to go vertically. And I agree totally with the last speaker not to practice deep breathing exercises whilst having treatment. So if you inspire with the needle, it may increase risk. Again, a study would need to be done on it, but it may. And then follow-up, patients really shouldn't fly until there's been total resolution of the pneumothorax on the X-ray. They shouldn't dive or do any deep sea diving if they're going to for that time as well. But again, I've mentioned the smoking. And we definitely want medical follow-up if they're flying. So finish on a high, let's do that. But all patients had an excellent outcome, bar that one with a bilateral pneumothorax. The prognosis is good if they get to medical care quickly. All were asymptomatic at follow-ups, they were all fine, and all exhibited a normal chest X-ray at follow-up. So I would say that even when pneumothoraxes occur with acupuncture, the outcome is good, but it really shouldn't occur. Or from now onwards, I really want you to think about consenting them at risk if you're doing at-risk places. So I'm going to stop there if I can. And there we are, lovely. Hello everyone, back again and have a chat.
Thank you so much for that, Sarah. What we're going to do now is move on to Flora's presentation, because I want to make sure everybody gets to present, and then if we have questions at the end, we can ask them if we have the time. We don't want to run over. Flora has, there she is. I don't know how to make her the main person on the screen. Maybe when she starts talking, she'll come up as the main person. So this is Flora, who works at Lockton, and I'll let her introduce herself.
Okay, thanks very much. So just to let you know, I work at Lockton. We are the brokers for the Acupuncture Council, and my specific role is I head up the advocacy and risk management team. I'm a 15-year qualified medical defence lawyer, so moved across from private practice five years ago to Lockton, just to really focus more on events like this, really in terms of preventing problems in the first place from arising. So really trying to help our various clients. We represent lots of private hospitals, all the largest dental corporates, you guys, the Association of Optometrists, lots of numerous individual consultants and dentists, and we do some consultancy work for NHS hospitals and lots of out-of-hours clients as well. So it's a very sort of varied role, and I represent individuals at inquests and regulatory hearings, as well as in civil claims. But a big role in terms of the broking role is to be your advocate, and we are the intermediary really between yourselves and the insurer. So if the worst happens in one of the two cases that we've discussed and there is a full-blown claim, then it's our role to very much help you as the individuals as well as the council to get the best result that we can, whether that is defending you all the way, potentially to trial, or whether it's trying to settle immediately. And a big part of that is making sure that insurers are doing what we all, collectively want them to, because sometimes an insurer's interest can be slightly different to you as the individual or you as the council. We don't really have time to go into all of that, but I'm just going to look at this more from the perspective a little bit specifically to do with pneumothorax, but it's more generally just around what happens if things go to litigation and some of the issues that we see most commonly causing claims. Obviously, if something goes wrong, you can't underestimate the impact on the individual practitioner. We've heard a lot about how things could be done better, which I totally agree with, and I'll be reinforcing some of that. But I suppose partly what I want to do here is re-emphasise how important it is that if you can, take things slowly, try and consent properly, try and explain the risks, try and avoid things going wrong, then it avoids the awful situation that you can end up in if you are subject to regulatory hearing, disciplinary, civil claim, or worse even in some respects in terms of the ultimate outcome for the patient, obviously an inquest. So the impact can't be underestimated. And as I say, my role, because I'm so close to the individual practitioners across the board, I unfortunately really, really see it. And we've certainly seen with a number of GPs recently, the impact of, say, regulatory hearings and increased patient complaints can be terrible and drive individuals to suicide. So I think it's really worth just emphasising the fact that it can be a horrible impact in terms of stress. There can be media attention if a case actually does go to court. There's obviously, your reputation is built into that as well. There can be the financial implication, not so much for you in terms of the council will be paying the ultimate cost of any damages that are paid out, but there could be repercussions if, for example, there's reputational damage which results in fewer patients attending your clinic. And and the possibility of long-winded litigation. And again, I can't underestimate the amount of time that it takes. Even a little complaint is really difficult for you to have to give up your time to deal with. So again, this is just to emphasise that some of the things we see that lead to complaints could really easily be avoided. It's not me being remotely critical of any of you. It's just this is a pattern we see time and again because everyone is busy and everyone assumes that things are going to go well. And you also can't predict the response of the individual, because sometimes the individual, so in one of those cases we've heard that the individual was very sort of amenable and didn't actually want to take this further. But you were very fortunate in that situation. That is not the norm, I'm afraid to say. We tend to see the worst of humanity. I'm sure lots of people think lawyers are the worst of humanity anyway, but we tend to see the worst in terms of some of the complainants. We saw it during COVID. People were clapping the NHS with one hand, saying well done, and then in the other, bringing the most spurious, ridiculous claims and pushing doctors to the brink. So I think, I just sort of want to make that clear that you can't assume that just because you get on very well with a certain patient, they aren't going to cause you a lot of trouble if something goes wrong. So this is about, trying to avoid that. If the worst happens and you do end up with a complaint, what happens in terms of the actual sort of reality is, so both of those cases are cases that I've seen, and the first thing that happens is that all of the documents, so once it's clear that there's been an issue, and sometimes that it will emerge very quickly in a case like this, sometimes it will happen less, it will be less obvious early on, but we will have to say to you, once you've made contact with us, either via the council or individually, we at that point need to review everything. So all your texts to this patient, if you've been texting them, I would always say don't, but lots of people do. So texts, any photographs that you've taken of the treatment, or any photographs that the individual has provided in terms of the outcome that they're complaining of, such as burns, for example, which we see a lot following MOXA treatments. Voicemails, your attendance notes, your records, everything is relevant and everything will be scrutinised. Again, I'm not saying it to scare you, but it's just to sort of make you aware of the reality. And it doesn't matter whether it's a complaint or whether it's gone beyond that and it's a letter of claim from a law firm. Everything has to be looked at in order to help to draft a robust response, or else to help to draft a response which actually tries to settle the matter. If the case is a serious one, such as the two that we've discussed, and it's going to progress, the other things that we have to look at are the patient's GP records, the hospital records, the whole lot, because you have to look at the involvement of everyone that has come into contact with the patient. And whilst, particularly in those two scenarios, it seems that there has been no other potential cause for the ultimate outcome, you have to be sure of that. As a lawyer, you've got to make sure that you don't leave any stones unturned, and so we need to check that there's no evidence of an attendance elsewhere, and that's also why you try and get them to, i.e. the patient, to sort of talk about what they've done following their treatment. And then we also have to interview you as an individual practitioner. And at the very least, we need you to write an account of exactly what's happened with reference to your notes. Better practice is actually to get a full-blown witness statement, but at the earlier stages, where it is purely a complaint or an incident, then it's more just a written account that we then have to check against the notes. And then again, if a case progresses, anyone who has had an involvement with this patient will also be producing their statements. So obviously the patient themselves, if they are, if they're mentally, if they've got the capacity to do so, and if they are alive, they will be producing their own statement, and there'll also be statements from relevant family members, which can talk both about their experience assisting the individual, but also when it comes to quantum, which I'll come on to, i.e. the cost of one of these claims, they may be producing information talking about the amount of time and care that this patient has needed in terms of their recuperation and how that's affected their ability to carry out daily tasks and so on. in these cases as well, you'd probably expect to see statements from the A&E consultants involved as well. Then in terms of the real sort of nub of these issues, and this is something I can't emphasise enough really, the key is actually the expert witnesses. So we've obviously heard very eloquently from Sarah earlier, and it's individuals such as Sarah who are able to talk to the issue of the loss which has been caused. So the patient will be alleging that there has been some loss caused. And it's definitely not for the acupuncture council or the individual practitioner to start opining on whether this acupuncture has actually caused that loss. That is an issue for the expert witnesses, and that is an issue for the expert witnesses within Sarah's field. It is not an issue for acupuncturists to actually comment on. So acupuncturists, if it got to the point where we were at trial, acupuncturists need to keep what they are opining on to breach of duty, i.e. has there been a breach of duty? Did something happen during this treatment that wasn't done accurately? Are you able to comment on that or not? And that will include issues such as consent. But in terms of the causative point, that is actually something purely for those working in Sarah's field, or if we're talking about a burn, then it would be probably an A&E consultant or a dermatologist. So, we have to be quite careful that we don't go too far when we're responding to these claims. And it's another reason to make sure that you involve us as early as possible. We've certainly had it a few times with some of the burn cases where, and I can completely understand, you panic. It's horrible to have a patient complaining. It's horrible that a burn has developed. But we've seen quite a few of these cases where a patient goes away, we don't quite know what they're doing with themselves, and they come back, 10 days later, send these photographs where they look absolutely terrible. This area of the skin is inflamed and scabby or whatever's going on. But that is not necessarily down to what you as an individual has done. Other things might have gone on, and we've certainly had various examples of that. We do have examples of individuals who exaggerate, who lie, particularly now as we go into a recession. We're seeing a real increase in claims being brought. We saw it go an uptick during COVID, and it's even more now. It's the way you always see it with the economy and these cycles. So that's just a word of caution there, because if you start making causative links yourself and admissions of liability without us helping to look at it first, you are making it far harder to defend the case further down the line. It's not about not adhering to the duty of candor. This is not me saying you can't apologise or you can't, but it's about not making links which are not necessarily there. And I really have to emphasise that, because one of the problems you can end up with is if you do make a causative link and then you haven't involved us early enough, and that response is sent, then insurers can turn around and say, you've made an admission of liability here, so we aren't going to cover you. So I can't emphasise enough, make sure you come to us. We're here to help you. We're on your side. I can argue with insurers on your behalf. That is one of my jobs. I am an advocate, so I have to do that sometimes, but I don't want to have to do that. It makes it far harder for me and for you and everybody if I'm having to say, well, actually, they didn't really mean to make that link. It's too difficult. And just to sort of put that into context, the reason why this is so important is if we're looking at chest injuries, so let's just stick to the pneumothorax examples, the sorts of costs you can be looking at are, if it's a really, really serious chest injury, the most expensive chest injuries we see, the damages will be in the region of £95,000 to £141,000. That's where there's a removal of the lung and serious damage to the heart, and there's permanent scarring, suffering and prolonged pain. It's unlikely that it's going to be that serious, but certainly if a case is considered to be traumatic and and it can lead to sort of function impairment, so a permanent level of function impairment and disability, then you're looking at awards up to about 95,000. And then if there is, continual disability of some type in terms of lung and chest damage, then the awards are in the region of about 30,000 to 52,000. So, and even where there's just some damage to the tissue, no long-term significant effects on function, even those cases, you're looking at 11,000, 12,000 pounds up to, say, 17,000 pounds. And those are awards which are given for damages relating to lung injuries alone. So on top of those, you then have to add, have there been travel costs, medical expenses, care costs. The patient will have to show whether they've been off work, so they have to supply pay slips, all of that sort of thing. So that can then increase the award further. Those are what we call special damages, whereas the damages I've just referred to are general damages. And then there's costs on top, and unfortunately claimant lawyers continue to charge an absolute fortune. So you can bet your bottom dollar that if you're paying out, £100,000 for damages, you'll be paying out at least a further £100,000 for costs. And then there's the defence costs too. Again, it's not to be frightening, it's just to try and give you a bit of a sort of context around this from the legal perspective. So in terms of the main problems that we see in court, if a case does get that far, one of your main issues really in terms of the way in which a practitioner can be on the back foot, and indeed the medical profession as a whole, which is incredibly frustrating for me as a defence lawyer in this area, is that the courts tend to actually favour the patients. This is an ongoing issue. I've actually been to the House of Commons about this once. I'm going again in October. We're trying to sort of create a bit more momentum here, because there's a number of factors which are against you. One of them, as I say, is that there tends to be a sort of the court sort of bias towards patients, which is well known, and also the fact that costs in this area, it's very different to other areas of litigation. So if we go to court and we win, then you recover no costs at all. If the patient goes to court and they win, then they recover costs, i.e. you have to pay their costs. In lots of other areas of law, years and years ago I did construction litigation. If we were defending the case and we won at court, then the claimant would have to pay our costs. So one of the issues is, and again, it's just to sort of put in your mind, it's not to scare you, it's not to say it's not to say stop doing acupuncture, of course it's not, but it's just to remind you that if you get the small things right, you can avoid these issues, because there's no disincentive for a patient to bring a claim. Once they've got that kernel, which could grow into a relative 50-50 chance of success, they may as well bring it, because 9 times out of 10, it's a lot easier financially and everything else to settle the claim, because if we go to court and we win, it's essentially a Pyrrhic victory. So it's incredibly depressing, and I apologise profusely, but that's the situation we're in, and we've been in it since 2013, and it isn't a good situation to be in. So that's the sort of general context of what happens if a case progresses to court. Now, hardly any ever do. In terms of trial, I think it's sort of 1% of cases now go to court. But again, it's just to sort of set the landscape for you a little bit. One of the biggest problems generally is that whether you're looking at whether it's a case that goes to court or whether you're looking at it in the earlier stages during the pre-action protocol, which is where we essentially rehearse what might happen at court, and you send a letter of claim and then there's a letter of response. It's the problem of trust, and it's the problem of he said versus she said. So as I've already said, the court tends to favour the patient, and if it's not in the notes, then the assumption is it didn't happen. You've got insurers who are obviously really keen to settle a matter. So what we need to see, time and again we don't see this, is that consent was obtained properly and thoroughly, that the risks were explained and the risks were not played down, and that there's been good communication with the patient throughout. and actually, I think in a couple of these cases that we've looked at as well, particularly around safety netting, actually. And another sort of challenge can be where practitioners can develop an overly personal and intense relationship. This is a wider point, really, but just as I've said, text messages, emails, everything's disclosable. And you're generally, I would say, I've had acupuncture before, very sort of caring individuals who are offering these services, this treatment. I think probably as a patient, as a user, I think you probably speak to your acupuncturist in a different way than you might do to even your GP. A lot of people have got family GPs who they develop a relationship, but obviously a professional relationship, but a trust over the years with. But I think the manner is often and the whole atmosphere of going to an acupuncturist is very different to going to see a consultant, for example. And I think it can be a challenge for you to sometimes withdraw and not let individual patients use you as a therapist, for example, or rely on you too much. So those are some of the challenges that we can see when we go to court or when we're trying to defend a claim. And that's just something to flag, really, and certainly sort of unguarded text messages and so on. So I think just trying to sort of keep that veneer of professionalism, however tricky, is very important. Other issues that we see are, and sort of related to that, really, is not taking account sometimes of red flags to do with a particular patient. Perhaps they've got unrealistic expectations. I'll come on to this when I talk a bit about consent, but perhaps they have unrealistic expectations of you and of the treatment, and perhaps they've got some severe mental health issues or other issues which they are not dealing with, and they are trying to use acupuncture as a replacement for that. So those are all red flags, which I'm not saying you can't treat those patients, but I think it's just taking the time to think about those patients a bit differently, and certainly making sure that any issues that you raise with them are documented, and that they really understand what treatment they're going to be having with you, what the risks are, and that your treatment is not going to be a sort of panacea for all the issues that they might be generally facing. Trying to treat conditions that you as practitioners aren't qualified for is another issue. I've sometimes been a bit alarmed to see where individuals have treated patients and the patients have developed burns, and the practitioners are prescribing certain creams and so on, and then some of those creams can sometimes exacerbate the burn. I'm quite anxious when I see that. I would welcome some conversation about this when I finish. But from my perspective, I think it's probably safer to immediately refer the patient for treatment elsewhere. That might be me being over the top, but I think, again, it's just sort of flagging the fact that if you think medical input is required, then I would absolutely get medical input, and I wouldn't faff about trying to deal with it yourself and potentially making the situation worse. I think that if you think medical input is required, then I would just trust your gut and just do that as soon as possible. And again, just write the notes, make it very clear to the patient, and document that as well. And another issue that we've seen too is sometimes acupuncturists might treat friends, and we've seen some really nasty cases where friends, or specifically sort of lovers, have turned into ex-lovers and have made individual acupuncturist's life complete hell. We've seen some really, really horrible examples of that. That's just again a much more general point. And also getting involved in online spats as well. If you receive some nasty feedback, we certainly had this with an individual who was an acupuncturist's boyfriend. He then became the ex-boyfriend and was completely sort of terrorized her and slandered her online, and you should not then respond. Again, come to us and we can try to help you to deal with it and try to get posts like that taken down. And also, make sure that where you're using Moxa and so on, you actually understand the product and you know how to use it, and you've had training on that, because all of those can be sort of general problems and issues. Onto pneumothorax very specifically. One case we had was patient was receiving treatment for shoulder pain, and they suffered a pneumothorax when they were being needled. In that case, risks had been explained verbally prior to treatment, but there was no mention of pneumothorax and there was no written consent available. Now, there were other possible causes of this pneumothorax, as we've alluded to, so it could have been that sport that the individual was engaging in, could have been smoking, but the lack of the consent form made the case more difficult to defend. And I can't emphasise enough that it's a slam dunk case for a claimant. If there is no consent, it's very, very easy for them to say on the causation side of things, if you had consented me properly, if you told me that I risked pneumothorax, I just wouldn't have had acupuncture. We can argue against that. We can say, well, we saw, we've got your hard drive and we've seen that you Googled acupuncture risks 50 times and you would always have had this, or, you've tried all the different alternative therapies out there, so you were always someone that was going to try acupuncture. There are various arguments we can raise, but essentially, if you don't have that evidence that you have consented the patient properly, it's really, really, really hard to defend it. And insurers will turn around to us and say, we just want to settle this. We do not want this going any further. There was a very famous case a few years ago. I'm not going to go into the detail of it because of time, but it's the case of Montgomery, which you're probably all aware of. And that really re-emphasised, some people say it changed the landscape of consent. In some ways it did, in some it didn't, because I think in some ways it reiterated what was sort of common sense. I think the problem is we are now sometimes lumbered with unrealistic expectations, particularly in busy hospitals. But essentially what it set out was consent is obviously crucial, and the most important part of consent is actually the dialogue with the patient as an individual. So every single patient needs to be taken in isolation, and you as the acupuncturist should make no assumptions as to the information that specific patient wants to know or what they might consider to be significant. So you need to elicit all the information you can, which I know, from experience, you're very, very good at. I'd say you take longer with, will often take longer in the first consultation than, say, an individual consultant has time for in a hospital. But anyway, you will take all of that information, and then, at that point, you need to make sure that you aren't allowing your own preferences to influence the advice that you give and the language that you use. You need to be really sort of actively engaging the patient in the decision-making process, get them to ask questions, to then explore their needs, their values, their priorities, so that you've got a really sort of proper dialogue going on. And in that period of time, you need to be really ascertaining their views about the outcome. Have they got a realistic approach? Are they clear that you can't get any certainty or guarantee, for example, around the outcome? Are they aware of that? Are you being careful about your patient selection? So key is where there are some red flags, where the patient's being unrealistic, really think about, is this patient suitable for me to be performing various treatments on? What are their views around risk and also any potential recovery time? So Sarah referred to the fact that with the needling, they shouldn't then be diving or flying the next day. So are they sensible about that? Are they actually going to take heed of what you say? Document all the various options and risks discussed, and set out any recommendations that you've made as well. And it's always a good idea to sort of double check their understanding with a tailback in sort of areas like this. And I think another sort of key area really is separating out general limitations from personal limitations as well. Linked with that very closely is record keeping. So your notes need to be very clear. So you need to think about who will read them. Certainly have one eye on the fact that if there ever is a complaint and anyone else is looking at the notes, just be very careful about what you're writing. Don't sort of goes without saying, but don't write anything rude about the individual. If, however, they're aggressive to you, or if they're difficult, or if you have some doubts about their understanding, you can write that, but write it in such a manner that it's polite. What are you actually recording? What did you definitely say and discuss, and how can you prove that? When did you see the patient? So make contemporaneous notes and write up as you go. Don't leave it till too late. Make sure you're storing your notes safely, and also set out why you decided on a particular course of treatment as well. Now, I've got a couple more points I just wanted to raise in terms of what to do if you do receive a complaint. So hopefully, having heard these various talks, you won't receive any complaints. But if you do, the main sort of takeaway point really is to notify the council as soon as possible and complete an adverse incident report. Don't reply to the patient without consultation. Don't worry, we don't write a really legalistic response. We ghostwrite a response for you, essentially, which helps you to deal with the case in your tone and your manner, but just with the benefit and support of all of our knowledge. And you will see that response because you send it, but we will draft it and we will have various discussions with you around that. Don't make any admissions, as I've said already, however slight. And our responses will always be candid but prudent at the same time, very professional and factual, as opposed to sort of emotive or defensive. And just so you're aware, there's a team of us at Lopton who are all here to fight your corner, but also be realistic. Like I say, we're not going to defend things for the sake of it. But I lead the team, and there's 5 others with me who are all here to give you as much support as you want. So hopefully that makes sense. I think just to sort of emphasise what I'd say are the takeaway points, I'd say keep good, clear records of all your patient interactions. Consent the individual by looking at it from their perspective. Avoid overly personal relationships and online spats, as I've called them. Don't make causative assumptions, and certainly don't put those into your documents, and consult with us before you get into responses to complaints to patients.
Thank you very, very much for that, Flora. Flora's going to hang around now because we're going to open up to some questions, but I suppose I just want to add that we've got some handouts that we've done for people as well, which have summed up from a safe practice point of view, so not necessarily specifically from the legal or physiological point of view, but from a safe practice, from how to make this work in your own practice. And I suppose as well, with when Flora's discussing not making any admissions, that's after you've dealt with whatever you've dealt with. You know, if you think somebody may be suffering a pneumothorax, you send them straight to A&E. You can't sort of mix up an admission of guilt with doing the right thing as well. And it's, if there's a burn, then they need to seek further help if there's a suspected pneumothorax. So from my takeaway from that is make sure you know what those signs and symptoms are. Make sure you're clear in your mind. It's breathlessness is common, but it might not always be there. Pain is common, it might not always be there. But those things, as you know, as a picture, accompanied by having been needled in an area on the upper thorax or on the top of the shoulders, is always something that needs to be in the back of your mind, and to assess the person that you're treating and whether or not this treatment that you want to do is really the right treatment for that person. You know, we do have choices as acupuncturists as the points that we use, the treatments that we use. And if it's a very frail person, someone with a chronic lung disease, someone very, very tiny, someone with a lot to lose, you know, Felicity's explanation of the case study of the story was, you know, that person was much more expensive as well, because she was going for IVF in another country, you know. So on a personal level, that was a much bigger impact on her on a personal level. On a financial level, that was a much bigger impact on people at Lockton, and that sort of gives you that bigger picture. So that from a safe practice point of view, make sure you're assessing the situation from all of these levels, and not sort of doing what you want to do because that's the treatment that you want to give. Think about the extra. And as part of this, we have reassessed the consent form online, and it predated me, the old one, and we've done an awful lot of work on it. We've got Flora's legal help, our in-house legal help. We've put a lot of work into that, and there's an accompanying document there to help you fill that in, and it tells you a lot about what Flora's been talking about with consent as well, and gives you a lot more information and background there. So it went on Wednesday. Yeah, it went on Wednesday. It ended up very last minute, but we were determined to get it sorted for this weekend. So what I'd like to do is, we do have 10 minutes left, so I'd like to open up the floor to questions to either Sarah or Flora or myself, although it might be quicker to see me after. But does anybody have any questions, or have we thoroughly gone over everything you could possibly want to know about pneumothorax? We do have one moment.
You said about pneumothorax is happening. I mean, it is a rare thing, and you have to stick a needle in pretty hard, don't you? And how many people are actually British Acupuncture members has this happened to?
So the question was, how many British Acupuncture Council members have had a pneumothorax case, and do you have to stick the needle in really hard? So I suppose, Flora, do you know the answer to that first one? I've not got sound for Flora. Oh, you're on mute.
Sorry. I feel as though there've been about 10 or 12.
In how long?
So since I've been here 5 years.
So we're looking probably at more often than you think. So that's twice a year, and I actually do know of 2 in the past year, and so that concurs with exactly what I know of. And Sarah, about sort of, do you have to, the case study that Felicity was talking about, the practitioner had no idea that she'd put that needle into the pleura. So Sarah, you're on mute as well. Does that needle need to go in really hard?
Sorry, just repeating the question. You said that the practitioner had no idea that she might have breached pleura. I think that can happen. I think you won't always feel when you go through pleura. You often will. It will give. But there are definitely times, we can see all these times, nothing's done deliberately here, so there are going to be times when you go through without knowing it, and most of the cases I've heard of, the practitioner has been unaware, it's been on a later phone call. I think there are those that you immediately know because they'll immediately get pain, and the practitioner does know. They're in many ways less of a concern, aren't they, because you immediately act by getting ambulance or advising going to ED. So I don't think it's going to be uncommon not knowing, but they should. Again, people will have chest pain that's unusual, maybe not around the site of the needling, and they will get breathless.
Thank you, Sarah. So I suppose the takeaway from that is it's a lot easier than we think it is, and the practitioner that we were discussing earlier was a very experienced, very experienced practitioner. So it's just, and I think my particular sum up of that particular case and of a lot of the pneumothorax cases, or the 2 I've dealt with since I've become the safe practice officer at the BACC, is make sure you're using the right needle length. I think that's been a common problem, is that people, if we've all done it, we've all run out of the right sort of needle and used a longer needle than we would, over the lungs, that's really not something that we should be doing. You need to be making sure, because we have those recommended needle depths in Deadman. We have the recommended needle direction. You know, we're all very familiar with that. We're all taught. I was taught that by Felicity 100 years ago, it feels like. And but we have to remember that those are relative to every individual. That's why we use sun. That's why we use that relative. You know, it's not a centimetre, it's not an inch, it's a sun, which is, you have to gauge that on the person as well. So that's something I'll remind you of now, is use the right, remind yourself of the symptoms of pneumothorax. Remind yourself to use the correct needle length. Remind yourself of the needle depth that's recommended. Look at your patient, look at the whole patient, and decide if really this is the best treatment. Is there too much for this person to lose? Are they too frail? Are they too thin? Are there too many red flags there well, we wouldn't call them red flags, but there are too many warning signs there to treat that individual over the lung area. Be I suppose, broader-minded when you're thinking of treatment, rather than just thinking, well, this point's the best treatment for this person. Think of that bigger picture as well. And a few of the other things, to be honest, I'm not going to repeat everything that I've written down on here, because a lot of this is written down here. It's a very basic, very simple sheet that we've uploaded onto the BXC website. I'd advise all of our practitioners to really familiarise yourself with it. And if there's any more questions, we do have some more. So this lady's hand went up first. So.
Thank you. It was just a quick question about the gradual onset of a pneumothorax and how long that generally takes or could take.
Sarah, one for you. The gradual onset of a pneumothorax, what sort of time frame are we looking at for symptoms occurring?
So it's really variable. So it can, I think, with an external, you can get symptoms in a younger person that will go on for up to 2 days. So I always try and explain that people are quite able to live on one lung. People will have one lung removed or have transplants, etc. So think about it that way, but it's progressive breathlessness. So someone's breathlessness is not getting better in context of still doing the same amount of activity. So, for example, if the patient in the case described felt better and the breathlessness was better, I would still say, are you not breathless going up the stairs? You know, is your breathlessness better when you're doing things? So make it contextual. But answering to the question, it can be really from trauma, it can be from anything up to 0 to 2 days. But it's the progressive nature of the breathlessness or pain that should worry you. Can pain or breathlessness suddenly get worse? Yes. So it can be quite steady, and they can feel a little bit breathless. And like the case I did in the slide set, that guy got suddenly breathless over 3 hours. So you always need to warn people, if you get suddenly more breathless, please do seek medical care. You can give me a ring if you're available all the time. My concern would be if someone got suddenly breathless and didn't quite know where to go. So on a consent or any advice, if you are dealing with a higher risk patient, please say if you did suddenly get breathless, then please do seek some medical support.
Thank you. And that is on the new consent form. We've put that on there, and make sure your patient understands what they're reading. So how many people do you pass a consent form, they sign it and they give it you back? That's not to be encouraged. That's why we get Flora involved here, because it's about making sure that they understand what they're consenting to, as well as the other things on that form. Understand what the aftercare is, understanding how to react if they're unwell, because a lot of people, I think, will just think, oh, it's probably just the needle that I could just feel the needle, and I think a lot of practitioners may have said that as well. Not any that I've spoken to, and not any here, obviously, but it's something to be very aware of, that these symptoms can be dismissed quite easily.
Can I ask a question?
Yes.
Could I ask a question?
Yes.
My question really is further to your point. I mean, would it be normal for a patient to be breathless after having an acupuncture treatment?
No, not breathless. We
So
have.
that's your answer, isn't it?
Yes, not breathless.
Really. So if it's not normal, then you need to say, actually, if you do feel breathless, it's out of proportion to your normal breathlessness that you may have, then that's a red flag.
Brilliant. Thank you, Sarah. Anybody else? We have another question.
I'll make it quick. Thank you. Probably a question for Flora, I think maybe. Is that when something happens in clinic like this, your natural response is to apologise, but I think you said that there's a subtle difference between apology and admission of guilt, and you're saying what you advise is not to admit guilt. But how when does an apology become an admission of guilt, and is it an admission of guilt?
Yeah, I heard that. So no, an apology isn't, because you're able to say, I'm sorry that I'm sorry to hear about the symptoms you're reporting to me, or we can phrase it in such a way. I mean, I'm loath to give sort of suggested wording, because it's one reason why we suggest that we strongly advise, and it's the council's advice too, is that you come to us to help you to craft the response. And obviously, as Hannah said, this is in the situation where something's happened and there is a complaint or an ongoing issue, and assuming that you've involved any sort of external medics or anything like that you need to. But I mean, I think the main thing to avoid is, we've heard two cases here where the damage, it seems sort of conclusive that the damage was indeed caused by the needling that took place, but there can be lots of occasions where there are multiple factors causing an outcome. So I think the main takeaway point for me is it's avoiding saying, you're right. So I've seen wording like this, you're right. What I did on X date caused this, and the point is it may not have done, because we don't know, particularly, as I say, with things like some of the burns and so on that we see, we don't know whether the patient has adhered to all of the aftercare, for example, or if they've decided to sort of put something onto, I don't know, a slightly sore red patch or whatever. I mean, arguably a slightly sore red patch shouldn't be there in the first place, therefore you've caused it, but you don't know. The patient could have some underlying skin issue that they've not told you about, or that they didn't know they had. So I think it's just about, so you can say, I'm really sorry to hear that you feel this way. I'm really sorry to hear about the symptoms you're describing. But then it's then just pausing, and it's then about trying to look at it in detail. So it isn't easy, but yeah, it's just really about avoiding sort of adding two and two and making eight.
I think I have quite a good example of that, and it will just be 30 seconds because it's time for this session to be over. But I did speak to an acupuncturist earlier last week who had a patient had a pneumothorax, and she had acupuncture prior to the pneumothorax, and so the acupuncturist immediately was starting to worry them, because you put two and two together. However, upon further investigation, that patient had also been to see an osteopath who had done a lot of work around the lung area, and there had been a previous injury of a rib that had not been diagnosed and was then found. So it's very easy to turn around and say, oh, you've had acupuncture, I'm so sorry, you've had a pneumothorax, and you put those two and two together. However, actually, it turned out there were many other factors that could have caused this pneumothorax, and it wasn't the acupuncture, it was a displaced rib that was moved in an osteopathy treatment. So that's a good example, I think, of that, and it's very much standing back, being sympathetic without admitting that it's you that's done that, even if you think you have. It's stepping back on that. Any more, or shall we let you go for your break? We've really bombarded you with pneumothorax information, haven't we? So I hope you've enjoyed our presentation today. Thank you for Flora. Thank you so much to Sarah and Flora for joining us today. Absolutely wonderful and hugely informative for us all, and hopefully will save us from problems, both with our patients and with ourselves. So thank you to Sarah. Thank you to Flora. Thank you for coming today. If you have any issues or any questions, please email me or give me a ring. Thank you.